clear aligners, not to use a pun here, are a good fit because primarily, I just mentioned compliance before, the majority of the patients that I'm doing are adults for two reasons. One, the adults are going to be compliant because they are paying for the procedure. They're sold on the procedure. They are going to pay for the procedure, unlike a child or a teenager who is not paying for his orthodontic or her orthodontic care. The ability to comply comes way down. Now, that being said, I do work on teenagers and we assess them. And if they are really excited about wearing aligner therapy, we will do that with them. But you have to have a really strict protocol with your younger patients. If not, they're going to become non-compliant and create all kinds of issues. But the fact that most of the people we are treating are adults shows you that clear aligners are excellent for them. And as your adults get a little bit, as your adults get a little bit older, they have the finances and wherewithal to deal with these types of cases. People always ask me the question about dental insurance. So even if you have dental insurance, we find that most companies are designed for long therapy. The therapies that we're going to advocate for your starting cases are not long therapies. So even though a patient may come in with, let's say, $1,000 or $1,500 orthodontic maximum, most insurances pay monthly. They pay X amount of monthly, could be from $70 to $120. So if a patient's in treatment for, let's say, 6 months, no way are you getting close to their $1,000 or $1,500. So that's just an important little tidbit to remember when patients talk to you about dental insurance. You really can't count on it like you may do in your general practice for operative dentistry or crown and bridge or prosthetics, other prosthetics. So let's talk about what happens on a daily basis. If your hygiene staff and you see anywhere from 12 to 20 patients a day, so it's roughly, let's do the math over here, let's say that's 48 to 80 a week. If one patient accepts treatment per week, you're going to be doing the 40 to 45 cases per year. I just had somebody come into my office and ask me, why am I doing so much aligner therapy? And the answer is simply because I talk to everybody about it. We all know in baseball, the people who have the best batting average are the same ones who strike out the most. I put the seed in a patient's head, and then we start to move forward from there. We make a note in their medical record, and then we touch on it again when we see them at their recare visits, either in 6 months or a year, whatever. Remember we spoke to you about that or so-and-so, and the patients remember it, and you do this enough times, the patients say, okay, I'm ready to do it. Why are they ready to do that more than maybe that crown or maybe putting a bridge in or maybe doing an implant? Because it's easy. It's easy therapy. It's not painful. It's something that the patients can do themselves and see the results themselves. So it's really about our desire. It's the desire to help our patients. The second one, expand your services. It's so crucial in today's day and age. And it's also desire to attract and keep patients in your practice. When patients start talking or they're going out to dinner and they excuse themselves and they pull an aligner out of their mouth and their friend says, what is that? And she says, oh, I'm getting my teeth straightened. And despite all the marketing, patients don't know, or the consumers don't know, that something as simple as an aligner can move teeth and straighten teeth. And obviously, the last desire to grow your practice into something successful. So some of the comments that I've heard when I talk to doctors about bringing aligner therapy into their office, they tell me, it's too hard to do because they're thinking of standard orthodontics. It takes a lot of time. My patients aren't going to accept treatment, and my orthodontist, if I start doing it, he's not going to like me anymore, and I'm going to have all kinds of flack for him. It's really not true. First of all, too time consuming. It's not at all. Aligner therapy takes nothing more than a crown prep time to do. Half hour, 40 minutes, maybe an hour, if you combine the initial appointment and maybe even delivering of the aligners. It's too hard. It's not too hard if you pick the right cases. And this is so important. The cases have to be picked properly. If you don't pick the cases properly, then you're going to get yourself into a pickle. So the cases have to be cases that you can accomplish in a short period of time, get in, get out, and then move into retention. Patients will not accept treatment. Well, I have this discussion with doctors all the time. How do they accept any treatment? How do they accept the fact that Mrs. Jones, you have gum disease? Or Mrs. Jones, I see your radiolucency. I believe we need to do endodontic therapy. They will accept treatment. If you don't have confidence in your own ability, patients feel that and patients know that, and they're going to say no. I just treated a patient last week for a crown. He saw another dentist, and the dentist wasn't sure what he needed to do. And the question was whether they needed endodontic and endodontics and crown lengthening before the crown. And I assessed the patient. I told him, you need this. And he says, wow, all I wanted was somebody to tell me what I needed to do. We can't underestimate the ability to communicate concisely, clearly, and authoritatively. This is the treatment you need. And once patients hear that, they have confidence in you because you have confidence in your voice. And the last thing, my orthodontist will hate me, not at all. If you're on the lookout for orthodontic cases, and as your knowledge of orthodontic cases increases, you know what it'll take, because patients always ask you, if I go to the orthodontist, how long will it take to do this case? And if you have an idea on more complex cases because your orthodontic knowledge has grown, it's a win-win for everybody. Your orthodontist is not interested in doing the small cases, the initial cases, the light cases, for lack of a better word, that you're going to be doing. He'd rather be doing the more complex cases. So you're going to be referring more to your orthodontist. He will be very happy. In fact, he will help you. If you run into a bind, he will help you with your cases. So the subject of today's webinar is the 5 pillars of ortho-aligner success in a general practice. And the 5 pillars are on the screen in front of you. First of all, you have to identify your patients. And once you identify the patients, you have to talk to them about it. You need to find space. We'll talk about what that means. There's a sweet spot of money and time. Something that's too expensive and takes too long is a turnoff for many people. Your records have to be concise and precise, and you need consent forms to make sure that the patient knows where they're going, what you're doing, what's the scope of the practice. So let's talk about these 5 pillars and move forward from there and how we can bring this into our practices. As I mentioned before, adults are your best candidate for clear aligner therapy, and especially those who had braces when they were younger. Patients had braces when they were a teenager, and we all know what happens unless they have a lingual bar. Then there's going to be some type of orthodontic relapse. This is a phenomenon that we all see. There are many theories as to why the lower anteriors have a tendency to collapse in, but doesn't make a difference what the theory is. This is what happens. So these patients are walking into your office every single day. And the other reason that I mentioned before, and I'll dwell on it a little bit, is that for aligners to be successful, you need patient compliance. The adults who are paying for the aligner therapy will wear their aligners. So you have many, many choices on how to identify the patients. And once you see them, put the seed into their head, put their seed into their mind. And so they know that what you can do to improve their smile. And they may never have noticed, gee, I didn't notice that tooth was crooked, or that space never bothered me. It's easy enough to fix that. And especially if they're coming up on some type of life, a life cycle event, such as a wedding or a reunion or a family gathering, that's the time, if you can apply some quick aligner therapy and get them done in a few months, those are the patients who are the most successful to going ahead and becoming one of your patients with clear aligner therapy. So the most common time that we talk about this is when you have a relationship with your patients. I do not normally, unless the patient comes to me specifically for an orthodontic consultation, I don't usually focus on that at an initial exam. We may just mention on it, but we don't make a lot of we don't spend a lot of time focusing on it because I want to develop a relationship with the patients. The patient that you are close with and have a relationship will take your advice. The patient you just met, unless you can give them a solid reason, a good reason that they can feel and touch to do therapy, are not going to move, ahead. And even though you talk to them about periodontal health or the ability to do minimal restorative dentistry, they can't relate to that because that's something in the future. They need to hear something now. Once you have a relationship with them, the ability to inform them and educate them at that point, they have much more conducive hearing at that point. So what kind of cases are you looking for? Primarily, we're going to be looking for cosmetic cases. And very simply put, second bite to second bite, maybe in first bite to first bite. You're looking for slight spacing. The patient complains of packing food in between their teeth. A little bit of crowding. Midline discrepancy should be less than 2 millimeters. And a deep bite or possibly overjet, though patients don't really recognize overjet so much unless it's very large, should be also less than 2 millimeters. You may align teeth, as I mentioned before, with molar uprighting, though that's not what would happen over here, but it could happen in, let's say, a lower anterior bridge, or possibly you're placing an implant and the bone of the implant is either typically too lingual. By moving the teeth around, you can get the implant placement to be much more cosmetically acceptable and also easier to keep clean because you have everything in line as opposed to having a large ridge lap. You can look for cases where you may have to do extract an incisor, and we'll discuss a case like that a little bit later. Bicuspid extraction, we stay away from, unless the bicuspid is way out of alignment. If it's way out of alignment, then it's easier to close the space. That would be the first bicuspid. But if it's just a normal bicuspid that has typically 6 to 7 millimeters of space that it's taking up, that would be a challenging case to do. The case you don't want to do are just the opposite of all these. You don't want to have a large midline discrepancy, deep overbites where you're getting 30, 40, 50% overbite, major crowding, class 3 bites, or a full posterior crossbite correction. You're not going to correct a posterior crossbite with any aligner system. So that's why sometimes when you're talking to a patient and the anterior is crowded and the anterior is collapsed in, you can make the front of their mouth look better and leave the stable posterior crossbite because patients see what they want to see. And there's nothing wrong with doing treatment like that. Now, obviously, you can offer them, do you want to do full braces? And we'll try to correct the posterior crossbite, or the orthodontist you refer to will try and correct it. Most patients, most adult patients don't care. They just don't. They're looking at their anterior teeth. It's a fact of life. And they're happy to do aligner therapy on their front teeth. So once we come down to anterior teeth, again, we're looking for mild aesthetic cases. You're looking possibly preparation for veneers or some type of crowns, getting the teeth lined up, closing diastemas to allow the crowns to be a much better shape and more harmonious with the face. No molar movements at all, and the teeth are generally straight. So the refinement, the relapse cases are ideal cases to do this. Here's on the left side of the screen, we see lower incisor crowding. 24 and 25 are set lingually, whereas 23 and 26, not only they're labial, but they're rotated outwards. If we look at the right of the screen, we see damage from severe overbite. Obviously, you cannot restore these teeth either with veneers or bonding, or even with crowns because there's no room. There is no room interdental arches. So consequently, what ends up happening is, and the patient told me, he says, I had my teeth bonded many times. It doesn't work. Can you bond them for me? And the answer is no, I can't bond them for you. But what I can do is I can move those teeth and they will come back lingually. Now I will have some overjet. I will reduce the overbite, and now I can restore those teeth. And whether I decide to restore them with veneers or crowns, it's irrelevant at that particular point. We will have success. In this particular patient, the orthodontics allowed me to be successful with this case and move forward.